My name is Daniel Goldberg. I'm the founder and president of the Free Market Health Group. What we do is we do marketing, public relations, consulting, and direct contracting for physicians who are direct pay, cash pay, concierge, whatever you want to call it. I want to start by saying if you haven't read Sean's book, it's quite enlightening. It's outside. I would suggest picking it up. It teaches you a lot about the mindset of a cash pay patient. So as a physician, it's always good to understand the psychology of your patient. So we want to talk about if you are a cash pay physician, and we've talked all day about the reasons to and not to become a cash pay physician, but if you are, I want to discuss how to get patients into your door to make you have a viable practice. So to me, the most important thing about being a cash pay doctor is re-education. And re-education consists of basically convincing patients why paying cash is in their best benefit. So the first thing we have to do is dispel the inherent myth that cost equals quality. I think we all know that cost is not relative to quality. If you are providing an ACL surgery for $5,000 and the hospital-based physician is doing it for $50,000, it doesn't mean he's better. It just means he's charging more. What mostly happens is when we see competition based on price, we know that there is a quality there, and that's why there's competition, because the product is of some quality. I like teaching people about what insurance really is and the repricing that happens with insurance. So what your EOB says or what your benefits say and what actually your insurance company paid. If you teach patients about the insurance scam that they're a part of, they are much more willing to say, well, I want out of this. I want to do something for myself now. I don't want to be a cog in this machine. So that's part of the education. The other thing is patients who want to take control of their own health care, who don't want to be restricted by narrow networks or told by a bureaucracy where they can and can't go for care. Many of them will say, my insurance company says I can only go here, but I'm not satisfied with those options. I want to take control of my own care. And one of the biggest markets for patients is the employer and their employees and their benefits programs. Between 50 and 55% of people in America get their benefits from their employer. Part of what we do is take cash pay physicians, mostly surgeons and specialists, and bring them to the forefront of the employers and say, listen, you are paying this. You could be paying this. And it's usually about 10 to 20% of what they are paying. The employers love it because it's a cost-saving program. The employees love it because it gives them more options in terms of their care. So who are our markets for patients? And this is part of what my company does in the research process. So the first is the fallacy of the 1%. Obviously, it's not just the 1% of people who can afford cash pay. What the free market thankfully does is it lowers costs, which increases access and consumerism. So the 1% becomes 10%, 30%, 50%, 70%. And that's a product of competition within the free market. People have high deductible plans. I have a plan. My deductible is $6,350. I want it that way. I had to go to a gastroenterologist to have just something looked at, and he wanted me to have an endoscopy. Referred me to a physician who was part of a hospital, and that physician, first of all, getting the price out of that physician and the hospital was like pulling teeth. I had to call the administrator to find out what the professional fee was. Then I had to call the hospital to see what the facility and the anesthesia fee was. I just went online and through a lot of the resources Sean talked about and found a physician who was, every certification was a quality physician who charged me $1,800. Because neither of those were under my deductible, the $5,500 the hospital wanted to charge me, or the $1,800 that the private physician wanted to charge me, I'm a cash pay patient anyway until I exhaust my deductible. So I paid the $1,800. And I shopped based on price and quality like everybody does in this country with everything. You bought your shoes, your toaster, and your house based on price and quality. Medicine's the only thing we can't do that with. But if we have a more free market, cash-based system, we absolutely can. Self-funded employers, and this is something I haven't heard a lot about today, and this is one of the biggest markets we focus on, especially for specialists. Self-funded employers are employers who are paying the medical claims of their employees directly. So for basic things like primary care and tests, they do what's called rent-a-network. So they may use Aetna or Blue Crosses or somebody's network. But for specialists, they're not restricted to making basically side agreements with anybody they want and saying, fine, through managed care, we'll pay $8,000 for a knee. But through Surgery Center of Oklahoma or Regency Healthcare or one of these transparently priced global fee, which is important, global fee places, we could pay 4 or 5. So we'll use Aetna for our primary things, but we won't use them for specialty. If you're a transparently priced specialist, you have access to thousands of employees. because these companies who typically self-fund their benefits are at minimum of 100 employees and up to about 30,000 employees because they need the capital to fund the claims, and that's a whole different process. But third-party administrators, they're a great target to expose your services to because sometimes they manage one plan and sometimes they manage 40. If they're not being paid on the claims directly, meaning they're not getting a percentage of the billed charges, they'll bring this to every company they have because it's a cost savings model for them. The employer loves the TPA because they saved them $30,000, so they get their next 10 years of business. So it's a win-win for them too. And then there's the electively uninsured. The electively uninsured is pretty much my generation, 29 and under, who think that nothing bad is ever going to happen to them, and something bad does happen. So if I'm uninsured and I blow my knee out playing basketball, I could pay $50,000 at Mount Sinai Hospital, or I can go to a transparently priced global fee facility and pay $5,000. If I'm 29 and most likely employed, probably entry-level employed, $5,000 is actually reasonable. $50,000 isn't. I'm not going to spend the rest of my life in debt to a hospital either. Plus, I don't have enough collateral to enter most arrangements they would want, so I'm kind of screwed. There's also domestic medical tourists. So medical tourism is a $2 billion a year industry, meaning people in America spend $2 billion a year in India, Mexico, and China. Anyone who's willing to get on a plane to go to India to have knee surgery is sure as hell willing to go to Texas or Ohio or New York. We can bring that money back. It's $2 billion a year that gets injected back into the economy that we should stop losing. So this is what I want to talk about, leveraging transparency. And Sean touched on this, and I want to sort of expound on it. So this is one of our clients who basically has all their fees for service, and this is a sample, global fee, outpatient, listed on their website. So the idea, of course, is put your prices on your website, let people know what it costs. And there's a menagerie of other websites where you can put your stuff, like Sean said, DocCost, Pricing Pain, Healthcare Blue Book, Symbiosis Health. But you want to bring them back to where you are so they can learn about you, they can see your practice, they can see your credentials, see everything. So what do? This is where the technology and the marketing aspect comes in. We use simple things like Google. So if a patient types in, how much does knee surgery cost? I can tell 3 things about them. 1, they're in the market for knee surgery. 2, they're price sensitive. And 3, they're ready to make a transaction. Especially if they use words like, how much does knee surgery cost if I'm uninsured? I want to ring that person's doorbell and go to their house, let alone get them to my site. So using things like pay-per-click and SEO to bring them to your site using what we call transactional words. So what are people searching? What are people typing in that applies to them? When they type these things in, I'm going to show them my prices. The benefit is most people, if I'm in Michigan and the best doctor who, for the best price, the best quality is in New York, I'll go to New York. Surgery Center of Oklahoma is a perfect example of that. It's in Oklahoma. Every state has patients going to Oklahoma, including Canada. Everybody's going there. So in reality, location isn't that important. Transparency and quality are more important than location. So I want to talk about media relations, and this is, again, something Sean touched on, and my background is in PR, and I can tell you that there are about 1,000 don'ts and about 2 do's in terms of PR. So it's a lot easier to screw things up than it is to make them work. So it takes a professional to do this, but we want to leverage media coverage. So if you're a cash pay doctor and calling news and saying, hey, I take cash, do a story about me, sometimes will work if you're in a rural area or you're in an area with not a lot of news coverage, but try doing that in New York City. There you have 1,000 things to deal with that day, and there's no interest in you. What we do is we attach it to relevant stories. So yes, could anyone in this room opine for 2 hours about the shortcomings of Obamacare? Of course we could, any of us could. But that's not what the media is interested in. It's been done. So what are the alternatives? What are doctors doing in the face of these challenges? This is what we're talking about. Cash pay, global pay, transparency. This is what they're interested in. We offer expert commentary. So if you see an article that was written by a healthcare journalist or editor or saw a story on the news, call the producer and say, listen, I saw your story. I think this might be an interesting caveat if you're doing a follow-up story. They may not call you the next day, but they may call you in a month and say, I want to do another story about this. It got good reviews, or it got a lot of readership, or it got a lot of viewers. We want to do another story. Do you want to be a part of this? I have a client in New York City. They were doing a story about Medibid, and they asked one of my physicians, who's a transparently cash-based physician, to be a part of the story. What was in it for him was 3 minutes on air in front of 4 million people and talking about his practice. That's leverage. We want to identify the angles. Predominantly, we think that the news media that's covering cash pay or Obamacare alternatives is the conservative media. That's because that's the only place we're focusing. There's huge amounts of press coverage and leverage in regard to what this does for people who are uninsured, what it does for the immigrant population, and what it does for everybody but the 1%. So we identify those angles and don't just go to Fox News or the New York Post. We go to every different media outlet and give them a message to basically tell them for free media coverage about our practice and what we do. That's the art of the pitch. It's finding the angle that that outlet is interested in and giving them that angle and not just saying, this is the only thing I'm going to talk about. If you like it, fine. If not, take a walk. You have to be malleable and be able to wear a few different hats to get the word out there. These are some examples of one of our clients who I'm just picking from New York, who's been in several different media outlets. And as you can see, they range. He was on Sean Hannity. That's pretty obvious why. But he was in chief executive because we want to reach CFOs and benefits managers of companies to tell them about direct contracting. Crane's Business News, CBS News, all of them had a different message and a different approach to let people know that this is what we do and this is how it works. So if you're a primary care physician or anything but a surgeon really, there's collaborations. Primary care is partnering with specialists and surgeons is important. Every day, hospitals buy primary care practices to keep their referrals. It's the only reason they buy them. You can compete with that. If you're a cash pay physician, align yourself with specialists and surgeons and physical therapists and occupational therapists. Create your own ACO, and when I say ACO, I mean the one that really works and is not fake and made up. It's actually a real thing. But having a care path for a patient preoperatively, diagnostically, testing, and postoperatively. As Sean said, if they're relegated to only one specialty of cash pay, once it goes outside that scope, they're right back in the system. So if you can keep them outside of the system in the cash pay system, you're gonna have a lot happier patient. Create referral relationships with other physicians. So if you're a cardiologist or a nephrologist, make sure you know the local or even state-based cash pay primary care surgeons, everybody. Create your own networks. And then again, partnering with acute therapy and physical therapy, both before and after surgery, that's more if you're a specialist. Make sure that you're not just scoping a knee and then saying, have fun, go home, best of luck to you. Give that patient a defined care path so they're more comfortable paying cash. The next thing I want to talk about briefly is direct contracting. This is something that hasn't been much discussed. This is an example of direct contracting. So Walmart and Lowe's collectively have 1.5 million employees. And a lot of their employees, they saw a trend needing hip and knee replacements. So they went to 4 major hospital systems in the country and said, listen, if you give us a global fee or basically a reduced rate, we'll send all our patients to you. And Johns Hopkins and the Mayo Clinic, the 2 other hospitals went, 1.5 million employees? Yeah, fine, we'll do it for whatever you want. So Walmart and Lowe's created a deal through a company called the Pacific Business Group on Health to provide no-cost hip and knee replacements for all their 1.5 million employees. The reason it's no cost is because it's far less than what they were paying through managed care. They created a direct contract between the hospital and the employer. The patient didn't have to pay a co-insurance because at that point it's negligible. If it went from $50,000 to $10,000, why do I want the patient's $5,000? I'll just pay the whole thing. Because they're not relegated only to those 4 places. They're incentivized to go to them. So if they go outside of these 4 places where they can get free care, they're subject to whatever their deductible and their co-insurance is. But if they go to one of these 4 places, it's free. And they're not going to some hole-in-the-wall clinic, they're going to major institutions. That's an example of direct contracting. We do that on a much smaller scale with less than 1.5 million employees, but we still do it. And what we do is we take, by CPT, by procedure, by whatever the employer wants, and bring it to the employers, usually the benefits manager, the HR, the CFO, whoever's controlling the outflow of money for medical claims. And we show them, here's the menu. This is what you pay, typically through managed care. This is the local hospital price. This is the local whatever. This is what you could be paying. These procedures are outpatient, done in surgery centers where there's a much lower rate of infection. This is what you could be paying. Just offer your services to your employees as part of their network and see where they go. they all always go to the places they have the contract with because the employee doesn't have to pay anything. They vet the doctor, obviously, so the patient's going to say, okay, I can see Dr. Smith to have knee surgery, but who's Dr. Smith? And they do their research, and they find out that these people are board certified, accredited, and have all the things you would ever need in a doctor. And they say, and I have to pay nothing for it? Yeah, I'll go there. So typically, again, they're larger employees with anywhere from 100 to 10,000 employees. If we talk about incidence rate or just rates of illness per person, you have quite a large pool of people who are going to come to you. If you do this with multiple companies like we do, and contract with maybe 70 or 100 different employers, you'll have a pretty busy practice. Again, you have access to large patient populations. The best part is there's no claim denials and there's no arbitrations, meaning that you bill company X for your services. Whoever's paying the bill looks at it and says, okay, we'll pay this because we agreed to pay this. And the payments are usually less than 14 days. So reimbursements go out with the next pay cycle. So the employees get paid 2 times a month, the doctor gets paid 2 times a month. So you don't have to wait, you don't have to hire a lawyer, you don't have to hire an army to chase down claims, nothing. You provided a service, you gave the employer a bill, they paid the bill, that was it. I don't imagine a much more fluid system of medicine. So that's briefly how we attract patients both on the individual side and the employer side to direct pay practices.